And now next speaker, Professor Dr. Manal Elmasry, and she is going to talk about tumor-infiltrating lymphocyte immunotherapy speeds up.
Good afternoon. Thank you so much for inviting me to present this lecture. After this heavy dose of highly informative lectures, I'll try as much as I can to simplify the lecture. And actually, I decided to simplify this lecture especially for our young doctors to understand the basics of tumor-infiltrating lymphocytes. Then I'll try to escalate after that till I reach the last article that has been published in Nature Journal last August this year. Okay? So, Bismillah ar-Rahman ar-Rahim. What are tumor-infiltrating lymphocytes? They're just immune cells that have left the bloodstream and then migrated to the tumor. They're part of the large category of tumor-infiltrating immune cells in variable proportions. Their abundance varies with tumor type and stage, and in some cases, they relate to disease prognosis. TILs can often be found in the tumor stroma and within the tumor itself. The baseline assessment, do we have a pointer? Does it work? The baseline assessment of the tumor cells, then disease progression, and the later assessment. Actually, sometimes we found the tumor, a large bulk of tumor, but actually this is called inflamed tumor. Few cancer cells, but the rest are immunogenic cells. As we see here, just few tumor cells and all the surrounding stroma are gaining way to attack the tumor. So, in a very simple way, what is the innate immune response? The first, which is the first line of defense, as it rapidly identifies and attacks the tumor cells. Oh, sorry. The first line of defense, it rapidly identifies and attacks tumor cells without antigen specificity. It recognizes activating and inhibitory signals from target cells to distinguish self from non-self. The NK cells are the main effector cells of the innate immune system, while the adaptive immune response, an antigen-specific and durable response, once activated, it can be sustained through the immune memory. The T cytotoxic are the effector cells of the adaptive immune system. The key stages of the anti-tumor immune response in both innate and adaptive immune responses, immune cells have the potential to recognize and eliminate tumor cells through three principal stages: by presentation, infiltration, and elimination. The innate immune system rapidly identifies and attacks tumor cells. Tumor cell death releases tumor antigens, which can activate the T cytotoxic of the adaptive immune response. The tumor antigens and other factors attract immune cells to the tumor site where they invade and attack, leading to elimination of the tumor by activated T cytotoxic that recognize tumor cells as the source of the antigen and target them for elimination. As the immune response continues to expand, some T cytotoxic mature into memory cells that may provide long-term immune protection even if the original stimulus is no longer present. So, what we want to mention that we have cold tumors and hot tumors. The cold tumors induce immune response while the hot tumors remove the brakes. Actually, if you want to get the full speed of a car, what you do? You press on the gas and you remove the other leg from the brakes. And now you can get the full speed of the car. That's right? So, in the hot tumors, where the stroma is heavily infiltrated by the immune cells, you can remove the brakes and get rid of the tumor. That's the principle. We can skip this. The anti-tumor activity of NK and T cytotoxic is regulated through a network of activating and inhibitory signaling pathways. Pathways that trigger the immune response and pathways that counterbalance the immune activation. So what are the functions of TILs? TILs dynamically change throughout tumor progression and in response to anti-cancer therapy. TILs are implicated in killing tumor cells. Their presence in tumors is often associated with better clinical outcome after surgery or IO, immuno-oncology or immunotherapy. How can we detect them and characterize them? Through immuno-histochemistry performed on CD3, 8, 20, 66B, SMA, and collagen. The immunohistochemistry has been used to detect lymphocytes in tumor samples, gene expression methods like microarray and RNA sequencing, allowing for systematic TIL enumeration and characterization of tumor microenvironment in diverse cancer types and across thousands of tumors. Regarding gene expression, detection of gene expression specific for different kinds of immune cell populations can then be used to determine the degree of lymphocyte infiltration, as has been shown in breast cancer. An active tumor environment within tumor often indicates a better prognosis. What's the adoptive T-cell transfer therapy? The use of TILs as an adoptive cell therapy to treat cancer was pioneered by Dr. Rosenberg and his colleagues in the NCI in the States. Rosenberg and colleagues have conducted clinical trials for more than 2 decades using TIL adoptive cell transfer therapy for melanoma specifically. TIL adoptive cell therapy is now a routine regimen in centers across the world, including MD Anderson, where the objective response rate originally observed in the NCI have been reproduced. Several centers currently have established TIL therapy protocols for the treatment of melanoma and lately metastatic breast cancer, including the MD Anderson Center in Houston, Texas, Copenhagen, and Denmark. How we can expand TIL? In adoptive T-cell transfer therapy, TILs are expanded ex vivo from surgically resected tumors that have been cut into small fragments or from single cell suspensions isolated from the tumor fragments. Multiple individual cultures are established, grown separately, and assayed for specific tumor recognition. TILs are expanded over the course of a few weeks with high dose of IL-2 and other conditioning media and enriching media, of course, who practices cell culture and stem cell culture, of course, they know how we can expand this. Selected TIL lines that presented best tumor reactivity are then further expanded in a rapid expansion protocol, REP. The final post-REP TIL is infused back into the patient. What's immunoediting? Immunoediting represents a complex and dynamic process involving cancer and immune system cells composed by 3 intertwined phases: elimination, equilibrium, and escape. A large number of immune cell subtypes are involved, each playing a peculiar role in interacting with cancer cells. Cytotoxic CD8 positive cells play a main role in cancer killing, of course, by inducing tumor cell death, while FOXP3 T regulatory Tregs represent an immune inhibitory cell type. The evaluation of tumor-infiltrating lymphocytes has been shown to represent a reliable surrogate of immune anti-tumor activities and a robust independent prognostic biomarker in breast cancer patients, especially in the triple-negative and HER2 positive subtypes. And actually, in Nature journal that has been published on the 7th of August, 2 months ago, they succeeded to eliminate almost totally the cancer cells from a late-stage metastatic breast cancer that was not responding to any treatment. Regarding pretreatment, the process can also involve a preliminary chemotherapy regimen to deplete endogenous lymphocytes in order to provide the adoptively transferred TILs with enough access to surround the tumor sites. This chemotherapy regimen is given 7 days before the expanded TIL infusion. then lymphodepletion is thought to eliminate the negative effects of other lymphocytes that may compete for growth factors and decrease anti-tumor effects of the TILs, depleting regulatory or inhibitory lymphocyte population. So this is the way to be done in the lab. First, we take the biopsy, fragment the tumor sample, and isolation of tumor-infiltrating lymphocytes, either by genetically engineered cancer-specific T cells or through long-term culture and adding IL-2 and other conditioning medium and enriching medium, then re-infuse them inside the patient. So, regarding, for instance, breast cancer, TILs isolated, selected, and grown to large numbers and re-infused, or isolated from blood, retroviral insertion of TCR, genetically engineered cells grown to large numbers, then genetically engineered cells infused with IL-2 again to the patient. Clinical success. Clinical trials using TILs to treat digestive tract cancers such as colorectal cancer, lymphomas, and cancer associated with human papilloma. In colorectal cancer, TILs are associated with microsatellite instability cancers, and also TILs are associated with most effective immune checkpoint inhibitor therapy in gastrointestinal cancers. They are an important prognostic factor in melanoma and higher level, being associated with better outcome. TILs are also associated with better outcome in epithelial ovarian cancer, as well as I said, metastatic breast cancer, with a great success, being published on the 7th of August this year in Nature Journal. The use of TILs to treat other tumor types, including lung, ovarian, bladder, are under investigations and hematologic malignancies. Association with cancer treatments, TIL therapy in combination with prior immunotherapy treatments such as IL-2, anti-CTLA-4, ipilimumab, has higher response rates and more durable responses in clinical trials. This suggests a synergistic effect of prior immunotherapy with TIL therapy. Current studies involve investigating the role of chemotherapy drugs in combination with TIL therapy to assess improved response rates and synergistic efficacy. What's the take-home message? TILs are implicated in killing tumor cells? Yes. They're important prognostic factors? Yes. Their presence in tumors is often associated with better clinical outcome after surgery or immunotherapy? Yes. Selected TIL lines that present best tumor reactivity can be further expanded in REP, rapid expansion protocol, and infused back into the patient? Yes, been succeeded. TIL therapy in combination with prior immunotherapy such as anti-CTLA-4 as well as chemotherapy together with IL-2 had high response rates and more durable responses in clinical trials. Thank you so much.
Thank you, Professor Manal Elmasry, for this interesting lecture. And I think we're short of time, so we'll close this session. Thank you.